This
webinar.
conference will now be recorded.
My name is Randy Gers, and I'm the Rural Health Clinic Program Manager at the Oregon Office of Rural Health. We have invited Kate Hill from the compliance team to present an RHC compliance webinar series. Today's webinar is RHC Compliance 101. On Wednesday, January 15th from 12 to 1, Kate will present the second webinar in the series Compliance 201. Thank you for attending today's webinar. Please be sure to mute your phone or computer. I will also post the link to watch the recording of this webinar on the Oregon Office of Rural Health website. And without further ado, I would like to present Kate Hill.
Well, thank you very much, Randy Ann, and hello to Oregon. I am in Pennsylvania, so I have been in your lovely state one time and enjoyed it immensely. So let's get started. There's a lot to cover. Our Rural Health Clinic compliance is loaded with facts and figures. So let's go. So let's start. We're going to do a survey today, and we're going to get about halfway through it, and we'll start with this. Let's get organized. So develop a survey readiness binder with your policies, your reports, other evidence of compliance. Try to find a space where the surveyor can work. And believe me, surveyors are used to small spaces. We're used to rural. Determine who will attend and how to inform them. And keep your clinic company ready, like at home, you know, where anybody could drop in anytime. If you don't have little children, it's relatively doable, and not if you do have little ones. It starts with being organized. It really does. The biggest thing on this whole slide is that the staff needs to know where things are. So we've had surveys where the manager is out and things can't be found, and that could be a deficiency, and you really don't want that to happen when you've got it done. So if it's in one place, it really, really helps. And remember, this is an open book test. There should be no surprises. All right. Now, I can't speak for the Oregon surveyors. I can only speak from the compliance team's perspective. So if things could be a little different depending on who you get that day, that's something I don't have any control over for sure. This is your book. This is your go-to, the RHC Conditions of Certification from 491 to 491.12. And the best place to find it is at the Cornell site. If you Google 42 CFR 491.5, let's say, it'll pop right up, and the Cornell site is excellent. Now, I will say this morning I discovered that they have not updated with the changes that went into effect on November 29th. So I've made the changes on these slides, of course, in their document, but they don't have the update yet. So the survey starts, as you know, when the surveyor pulls up to the door. A lot of things we're looking at here. Is the sign correct? Can a handicapped person get in the building? While rural health clinics are ADA exempt, we still need to make sure that our patients can get in our building. But the signage is a big issue for those of you that have been a rural health clinic for a long time. Did you slightly change the name over the years? Did you completely change the name and never tell CMS? Make sure it matches what was on your 855 application or any updates since that time, of course. 491.4 is about licensing. Before we get into the exact license for your providers, every person in the clinic needs to be run through the OIG exclusion list, and more state surveyors are looking for this. It is required by CMS. No one on that list can be hired in your clinic, from the receptionist to the housekeeping folks to the provider, nobody. So if you're on that list, it means you have a conviction of some sort of Medicare fraud. And so the easiest way to exclude everyone, and you must document this once a year. Some states have gone to once a month where there's a lot of fraud. We don't see a lot of fraud in rural. It is still required. So once a year certainly is adequate for us. So you type in you go to the OIG exclusion list, and make sure you are in the OIG list. There are companies that do this. You need to be in the .gov site. And then I typed in Kate Hill, and then, because I already knew I wouldn't come up. And then the sentence says, if no results are found, this individual or entity is not excluded. You must print that page. Now, you can also do 4 at a time. And so if you're doing your clinic staff, you can go through the whole list and type them all up at once. If the name Kate Hill had come up, The next thing is a middle initial, and then the last piece is a social security number, and that's how you can totally exclude someone. And with common names, that does happen. In the licensing, because you do have to track licenses, make sure everybody's up to date, et cetera, it's really good to have an organized HR file. This is easier for those of you who are provider-based because you've got an organization behind you who's got an HR staff person who's doing this sort of thing. But you want to make sure, especially when you're independent, that you have a checklist for your HR files that has the application or resume, that has the I-9 completed, the W-4, the OIG exclusion list, which we just talked about, a signed job description, signed and dated, I will add, standards of conduct, what's expected if we work in this clinic, performance evaluations. Now that's according to your clinic schedule. Certainly the least often is annually, but some of you have for new hires a 90-day, maybe a 6-month. That's by your policy. We don't look at anything if someone's not been there a year yet. Because it's so different, so we'll look at it once someone's been there for a year and expect to see a performance eval. Everyone should know how they're doing, what they can do to be better, etc. The annual training, a whole host of things that are required for annual training in the clinic. Competency, if they're doing something like labs, etc., they should be, it should be documented that they're competent to do those tests. And then background checks where appropriate. I didn't get the chance to check for Oregon to see if that's a requirement, but certainly if it is a state requirement, you must do it. And then it's also required if it's in your policy. If your policy says we will do a background check on everybody that works here, that would be in the record as well. Many companies who do background checks also do the OIG exclusion list, so you'd want to know that. TB screening on hire, and then more frequently as by your policy or by the state, and Hep B inoculation for those who work directly with the patients. Should someone in your clinic have had the Hep B series years ago, and they know they've had it, but you cannot find that documentation, have them sign a declination, and that's perfectly acceptable because they're signing their name, I don't want it at this time, because they've already had it, and that's absolutely fine. And your staff has the right to refuse that inoculation. So this is just a good checklist for your HR files and all the things that need to be in it. I will add that your I-9s should not be in the personnel file. They should be in a separate file, in a secure drawer, cabinet, all the I-9s together. Because should you be visited by immigration, they don't have any right to see the rest of your HR files, only those I-9s, completed properly, by the way. And of course, we're tracking our licenses, and we have a system to make sure that the providers all have, and nurses, et cetera, all have a in-date license. Yes, it's their responsibility, it's their work, but if the surveyor walks in and you have an expired license, it's your deficiency. And so we want to make sure that they're keeping up on those licensings. Posted hours, of course, on that front door. That is not a 491 regulation. That is Chapter 13, your billing requirements, but it is required that you post your hours. Many ways to do this. Some people put admin hours there, some do not, but you need to tell your patients when you're going to be in that building, such as this is posted here. 491.5 is about the location of the clinic. Before moving, and I take it that you're all rural health clinics. If some of you are just starting this journey to become a rural health clinic, it's a little different. But for those of you who are rural health clinics, check with your state office. Rondianne is a great person to go to, and your MAC to be certain that your new address is still in a HIPSA. You're grandfathered in where you are right now. If you're a rural health clinic with a CCN, you're in great shape. But that neighborhood may have grown up around you, and maybe it's not in a HIPSA any longer. And if you move even next door, you can lose your rural health clinic because it's not a HIPSA any longer. So you do want to make sure that before you move. Report any name changes to CMS and the medical director. Medical director is a reportable event to CMS, updated information, and it goes on your CMS 29 to the state. And then, of course, update your 855A or your CMS 29 as things change, depending on what the change is. 491.6 is the physical plan. So Part A is the construction. So the clinic is, or center, and that refers to FQHCs, is constructed, arranged, and maintained to ensure access to and safety of patients. and provides adequate space for the provision of direct services. Now, I copied this to leave the blue lines in there because when you're in the website on CMS or on that Cornell website, if you click on direct services, it tells you what that means, okay? And that here, of course, I've defined it means services provided by the clinic staff. So when you see ensure safety to and access of patients, that is a broad category. So we look for things like a back door that you have to turn a key or find a key to get out. It can't have that kind of lock. It should ideally be a push bar to get out, but we're looking for safety kind of things. Rural health clinics are exempt from life safety code, but that doesn't mean we don't have to be safe for our patients to some extent, but we don't have to do a lot of those other rules. Let me just hit adequate space. There are some states that have very specific, New York comes to mind, very specific measurements, square footage of the exam room. Most do not, but if yours does, then you'd have to pay attention to the space for provision of direct services. Maintenance, all essential mechanical, electrical, and patient care equipment is maintained in safe operating conditions. And the next one, drugs. I'm going to hit those in part 2 next week. Right now, let's skip to premises are clean and orderly. CMS has an initiative for 2020. It hasn't come out in writing yet, but it is going to be about hand washing. And there's no real place in the regulations to cite such things that we never saw anybody wash their hands all day. And that is a challenging one because you might wash your hand while you're in the room with the patient, and we don't see that, or nor would we have seen that. So it's a very big debate going on right now on what that evaluation is going to look like. But I would encourage you, only because we are still seeing infections caused by not enough hand washing, to encourage your staff to be washing their hands more often. But that's the place where it's likely going to get put, clean and orderly. So clean hands, think of it that way. When we sit in the waiting room, we present our cards to the desk and say we're here, and then they run in the back and tell you, and everybody gets a little bit nervous and says, call somebody, call somebody. While we're sitting there, we're looking for a variety of things. We're looking for safety. We're looking for torn cushions. We're looking for outlet covers if children are in the room and their parents are busy on their phones and they stick something in the outlet, those kinds of things. Mostly safety, tripping hazards, cords, rugs, all those kinds of things. So as we sit there. The first one on the left, I put that there because I really wouldn't be real happy with that rug if it would trip somebody, if it's got an edge that'll come up. And of course you can't tell that from the picture, nor can I, but just be cautious of that. The lamp in the corner, could that be pulled over by a child, that kind of a thing. The centerpiece is the table. Of course, this is an exam table, and how do we clean it? What is the wet time of the disinfectant that MA is using on that table? And she should know that. Now, the products on the market today run from 30 seconds to 3 minutes. If it's 30 seconds, we have no problem. Wipe, 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 put the paper down. But if it's 3 minutes, we need to go wipe the table, go to the waiting room, get the patient, and then pull the paper down. Otherwise, all we're doing is wasting our disinfectant and the paper. And so that's an important piece to the wet time. And it's right on the label. It's not like everybody shouldn't know that. The last picture is the patient bathroom. And there, if you open those under the sink doors, we would expect to find nothing under there. Probably could live with a plunger, but certainly no chemicals, no cleaning supplies, nothing under that sink in the patient bathroom. Other cabinets throughout the clinic should never have hazardous material under the sink. Certainly, they should not have any sterilized equipment or anything like that under the sink. The best practice is nothing under the sink. And I'll say that more than once. Sharps containers cannot be easily accessible. This sharp container is an operating room type sharps container, perhaps a procedure room where patients are never left alone. We would not be happy to see that in a clinic and would cite it. Sharps containers need to be mounted to the wall. They need to be locked so that patients in this society, particularly today, cannot put their hand in there to find some needles. So this is not an acceptable sharps container for a clinic. Now, several states require specific emptying times on sharps containers. I couldn't find anything in Oregon to tell me that that's true in your state. I did find that they should be read hard plastic containers with a biohazard sticker on them. And of course, that's pretty standard across the nation. If you have oxygen in the clinic, and we, of course, for our program, as an accreditor, we do require at least one tank for an emergency. But if you have more than one tank, you should keep full separated from empty so that in the event of an emergency, we don't grab an empty tank and waste some time when somebody needs oxygen. All oxygen tanks should be on an approved cart or chained to the wall in the clinic space. And certainly not in the heater room, in a controlled environment. Your postings, your state and federal postings are required to be in places visible to the staff. Most of the time we find these in the staff break room, if there is one, or certainly in the staff bathroom a lot of the times. Make sure you have the current year. We're now in 2020. We don't want to see 2019 postings up there. They're easily accessible on Amazon, etc. And a lot of them, like this one, have OSHA, the state hiring law, all on one poster. It doesn't have to be this way. You can post it as you will, but you must post the OSHA poster and the state hiring practices, laws. Provider-based clinics must have these postings in the clinic, even if the clinic is in the hospital. There is one exception to that I actually just passed the clinic that had the postings by the time clock, but the clinic staff had to clock in at that clock in order to get over to the clinic. And that was a unique situation. Most of the time, we don't see that the clinic staff is walking, doing a time clock and coming in that particular door. But this was a unique situation, so I didn't see any reason to change that in that facility. The left picture is a container that's soaking dirty instruments, so it should have a biohazard sticker. And then depending on what the process is by that manufacturer, what is the soak time? If there's a specific soak time, like 20 minutes, etc., then we would have a little timer there. Most of them are not. They can sit there and soak till you're ready to deliver them to be sterilized. I'm going to hold about that liquid nitrogen in a minute and move to the next picture, which is your outlet covers. Now this one appears to be the type where you slide, the modern type where you slide the plug a little bit to the left or right to push the plug in. That type would not need an outlet cover on it. Next are those syringes. Boy, we want needles, we want those needles locked no matter where they are in the clinic, okay? Now, if they're in the medication room is locked. But if they're in drawers in exam rooms, drawers in the lab where patients are going to get blood drawn, they must be secured. And again, it has a lot to do with our society today and what folks are looking for. The bottom one is thin prep in your exam table. We don't want to see it there. This is for your protection. This is a highly toxic material, and we're going to talk more about that in another slide. And then the last picture is the little one who's chewing on that. Actually, she's chewing on the plastic piece, but we're not going to expect to see any stuffed animals in your clinic. I don't think anybody will accept that any longer. They just can't be disinfected. Plastic toys, fine. You would have a process that you're wiping them down with regularity with the proper disinfectant. Next is the cleaning supplies in the clinic. So these are chemicals as well. The cleaning supplies and that little bit of medications there, we'll talk about that. And the meds are on for the next call next week. But both of these materials need to be locked in a cabinet or in a door with a pass key, a passcode, a key, whatever you wish, but they're locked away from the public. Exit signs. So everybody asks me all the time, do I have to buy these hardwired electric exit signs, battery operated, whatever? Here's the question. If it's dark, it's winter, it's 5 o'clock, you're still seeing patients and it's dark and the place begins to fill with smoke, can I, who've never been in your clinic, find my way out? That's the answer. If you can with what you're putting up there, that's fine. But it isn't going to be the word exit written in ink or with a Sharpie posted above the door. That's not likely to work. Reflective paint would work. Certainly battery operated signs. That's the best way to do it there. But again, just make sure we can get out of the building. Fire extinguishers are tagged and checked once a year unless there's a state requirement different than that. On the fire extinguishers, you're going to have an annual fire drill. let's put the fire extinguisher in someone's hands and make sure that they know how to use it and don't learn the day there should be a fire. Heaven forbid there should ever be a fire, but that's not the day to learn. It's like emergency preparedness exercises, which we'll talk about next week. We're going to prepare so that if an emergency hits, we know how to handle it with ease. And then floor plans. So floor plans are not required all over the clinic. Floor plans are required coming out of an exam room or other room where I can't see one of those exit signs. And so that's a very important note. So you've got to tell me as I come out of this room, which way do I turn? Don't put them on the inside door of the exam room, because when I open the door, I can't see it any longer. All fire safety processes, for the most part, are state regulated. So you would know what Oregon requires of you in terms of fire safety. HIPAA. So HIPAA, of course, is not called out in 491 anywhere, but it is a major problem. Now we see more problems with computers than we do with those paper charts, but just in case some of you are still on paper, we'll talk about both. Computer timeout. If we can walk into a room and see that computer there and it's still got the last patient's information on it, we have a problem. So your patients could read it as well. So either a very quick timeout, or the ideal, of course, is a log out. And that's up to your policy in your clinic on how you manage that. Is the NP carrying the laptop around the clinic, which we see quite often, and that's fine, and it's not left where someone could read it, that's perfectly acceptable. It's all about visibility to the public. And the visible PHI. So we don't see, that's obviously a clinic with paper charts. We don't see a lot of paper charts anymore, certainly some, but we still see faxes, lab reports, things that come out, and the front gal desk must be in charge of scanning them in, because there they sit. We walk up to the window and there's the results of somebody's mammogram with their name on it. So just be aware of that. Not a problem that she can't do that job, but they get turned over so nobody can read that till she gets them all logged in the appropriate place. 491.7 is organizational structure. So the basic requirements are that the clinic, and I apologize that these are so wordy, but there's no pictures here that are going to work, number one. And I wanted you to have the law right here so you could ask your questions and address things that are issues. The clinic is under the medical direction of a physician and has a healthcare staff that meets the requirements of 491.8. We'll get into that later. Now, a physician is an MD or a DO. That is a physician, the definition of, licensed in the state of Oregon. And when it's under the medical direction, he does not have to be an employee, but he is under your direction. The clinic is under his direction. He is ultimately, or she is ultimately responsible for the activities in that clinic. Disclosure. The clinic discloses the names, and we're going to say addresses only would be in a policy. You do not have to tell the public the address of your physician. We would not want you to do that. The person principally responsible for directing the operation of the clinic or center, and the person responsible for medical direction. So that's your manager and your medical director, and they should be posted to the physician, to the patients, to know who these folks are, should there be an issue. Staffing. Now, you have one or more physicians, one or more NPs or PAs to start. That's the basic staff. The physician may be a staff member. He may be an employee of the clinic. He may be under contract with the clinic to carry out these responsibilities. The PA, nurse practitioner, nurse midwife, clinical social worker, or psychologist may also be this member of the staff or the owner of the clinic. All right? In the case of a rural health clinic, at least one PA or NP must be an employee of the clinic. And the rest of them can all be contracted, but one needs to be an employee of the clinic. The staff includes other personnel, of course, and the staff is sufficient to provide the services essential to the operation of the clinic. How do we analyze that? The only real way this comes up is by a complaint. The phone rings and rings and rings, and the complainant will call us to say that, and they're obviously down staff, and that's usually what happens when we get that kind of a call, which does not happen very often. But that's where you would know. You know when you're down staff and you don't have enough staff, but you work quickly to fix that. Number 6, a physician, NP, PA, midwife, social worker, or psychologist is available, this is really important, to furnish patient care services at all times the clinic or center operates. We'll stop right there. That's the one that gets everybody. You must have one of those types in the building to do blood work, to do weight, to do a blood pressure screening. You cannot take the patient beyond that waiting room without one of those types in the building. Now, I get this complaint all the time. Well, I go to Quest and get my blood drawn. There's no doctor for miles. Yeah, you're right. There isn't. It is a law of rural health clinics. It is one we would love to see changed. It is from 1977, and I'm not quite sure why they put that in there, but fact is, it's really important that that somebody is in the building. Now, they can be in the waiting room. They can be get in out of the weather and wait till the providers. So by the law, you should not room the patients when the provider calls and says, I'm 15 minutes away, load up those rooms. I'm just going to tell you that's by the law. You wouldn't want that to be the day of a survey. Now, and further, a nurse practitioner, a PA, or a midwife is available to furnish patient care services at least 50% of the time the RHC operates. So that means if you're open 40 hours a week, that NP or PA, which is usually the case, is in that clinic for 20 hours, and that's documented by the schedule. Now, do they have to be seeing patients 20 hours? Absolutely not. The 20 hours can be, some of it can be admin. They're obviously there doing charting, et cetera, et cetera. That's the minimum that they can be in the clinic. And we have a lot of clinics like this. When it's NP owned, no problem. There's NPs all the time, or PAs. But when it's physician owned and there's more physicians than NPs and maybe just that one NP, he or she needs to be there 50% of the time. Now, physician responsibilities. So the physician performs the following. Except for services, well, we're not going to, that's FQHCs. I don't believe there are any, but if there are, I apologize. He's providing medical direction for the clinic, healthcare activities, and consultation for and medical supervision of the clinic staff, right? In conjunction with the PA or NP, participates in developing, executing, and periodically reviewing the clinic's written policies and services. What that means is, and it used to be annually, now it's biennially, every 2 years, the PA, NP, and the medical director, and the physician, have reviewed the policies and signed a paper that says January 8th, 2020, whatever the date is. I don't even know. I'm still confused from the holidays. So we know that it's 1 year, that it's within 2 years from the last date. A surveyor walks in the door. Right now, you've had reviews last year, so you're real good for a whole year yet. But it's every 2 years now. But the medical director, physician, must participate in that review of those policies. And then 3, periodically reviews the clinic's patient records, provides medical orders and medical care services to the patients of the clinic. What does your policy say about chart review? Oregon has, the NPs have wonderfully complete autonomy, so there doesn't appear to be any chart review. And correct me if I'm wrong on that, Rondy Ann, but I don't believe so from what I read today. So you still have to have this policy because you're in a federal program. But your your policy could say, we review 5 charts per quarter. We know this person. She owns the clinic. We're good with her care. The medical director's good with that. So 5 charts a quarter. You must document those 5 charts and be able to show a list to the surveyor that these 5 charts were reviewed in accordance with your policy. So some states have a higher standard in the state where they don't have autonomy like that. But for the federal regulation, you must have it. The number is yours to choose. You can choose 10 a week or 10 a quarter. It's your choice, but you just must live by your policy in your state. Now, the PA and nurse practitioner's duties, they participate in the development of these written policies governing the clinic services and participate with the review. So this is the back end. So we read the doctor's responsibilities. Now we're looking at it from the other way because that's how the law does. So it goes both ways. They participate in that review. So they're signing off on these charts. Now, I tell people, if you have a hard time keeping up with this review, don't your practitioners, your providers, non-physician providers, communicate with the physicians about a tough patient? You know, Mrs. McGillicuddy's blood pressure, I just can't get it down. Here's what I've tried. And let's use that. Tell them, make a note in that chart. Let's sign off on that one. There's one done. You know, that kind of thing. I know they do this. It's what medical people do. And so we would make it easy for you by just using those patients to meet your number. The physician assistant or nurse practitioner performs these other functions that aren't being performed by a physician, and that's provide services, of course, in accordance with your policies, arrange for referrals. CMS likes to see referral policies. How do we manage referrals? How do we know they're being seen? What's our follow-up? How long do we leave it open on our EMR until we get a result back, that kind of thing? How many calls do we make to the patient to say, are you going to do that appointment we're trying to set up for you? And of course, maintaining adequate health records and that they're transferred as complete as transferred for transfers. Sorry, I lost my voice there. Now, 4919 is the provision of services. So all services, of course, are offered in accordance with federal, state, and local laws. And again, I left the blue so that you can know that in the regulation, you can click on those and see what those words mean. Number 2 is critically important, especially last year, and I'm sure it will be this year. The clinic is primarily engaged in providing outpatient health services. What that means is primary care medicine, basically, rural health clinic services. Unfortunately, the 1977 law, actually it's the Social Security Act, excludes mental health. So we have to be very careful when we're adding things like Suboxone treatment or a good bit of mental health if you're fortunate enough to get it, that we don't go over that 51% on that side. It's something that we would love to see changed, but it hasn't changed yet. So be very careful that you're primarily engaged in outpatient health services. If you're doing other non-RHC services, and that can get very complicated, not just a 51%, but we want to make sure we're not going over that number with those services. The lab we'll talk about a little bit later. Patient care policies. So the clinic has healthcare services that are furnished in accordance with the law, of course. The policies are developed with the advice of a group of professional personnel. That includes one or more physicians, one or more PAs or NPs, and at least one member who is not a member of the clinic or center staff. So who is that person? That person could be anyone, any professional who has enough knowledge to be able to help you, who is not on the payroll of the clinic. It can be hospital personnel if you're provider-based. It can be your local pharmacist. It can be a board member from the hospital. Somebody who have reasonable knowledge to know what they're looking at to read and review your patient care policies. And that is an every 2-year event, and that's just changed November 29th. So no longer do we have to do that every year. Now, if you change a policy, you're going to have to go in and review it and change the policy. You wouldn't want to go 2 years to have a surveyor look at a policy and say, is this how you're doing this, when you're not? So, you know, that's obviously true. Anytime we change a process, we should change the policy. Number 3, the policies include a description of the services the clinic or center furnishes directly, and those furnished through agreement or arrangement. I think I have a separate slide on this, so I'm going to roll through the reg here and then go to the next slide. The guidelines for medical management of health problems, which includes conditions requiring consultation or referral, the maintenance of healthcare records, and procedures for the periodic review and evaluation of services provided by the clinic. These policies are reviewed at least biennially by a group of the professional personnel required under B2 of this section. Okay, so here's what I put on the policies. The policy states their services. That's what the law said. A description of the services the clinic or center furnishes directly. Let's stop there. So this could be in your healthcare policy says, for example, ABC Clinic provides primary care medicine for patients from birth to 99, or ABC Clinic provides women's health care. Whatever it is you do, put a simple description and you meet this standard. Now, the second part of it, those furnished through agreement or arrangement, make a list of those things you always refer. You know what they are: colonoscopy, cardiology, dermatology, you know, whatever it is that you normally refer, make a little list. They're the common things you refer, and you meet the second half of that regulation. Sometimes people don't even get around to looking at this, but you want to be on the safe side. It is in the regulation that you have this in your policy. It says, here's what we do, number 1, and here's what we typically refer. Okay? Now, the guidelines for medical management, this is a reference. It used to be you had to have a policy for diabetes and hypertension and hyperlipidemia and all those things. We're accepting a reference for medical guidance. Most of our clinics, and I will say most, use up to date. And a lot of them have it linked to their EMR. That is 100% acceptable. But put it in your policy that you use up to date as your guidelines for medical management, and make sure everybody who accesses that knows that's the answer if a surveyor should ask, what's your reference? What do you go to? The reason it goes in the policy that it's accepted by the medical director, because if we pick Kate Hill's primary care medicine, that would not be acceptable because I'm not qualified. But we would, so he has to sign off that that is an acceptable source, and certainly up to date is. So make sure that gets named in the if it's medical management or patient care policy, wherever in your policy you would have that information. Policies are, a lot of policies are required. So first of all, keep them organized. No, review a few policies each staff meeting. So now, of course, that's every 2 years, but then you don't get jammed up in this whole list of policies all at once. That's not a requirement. You do it whichever way is best for you. You can do them all at once, take a day and do them all. That's up to you. Keep your policies simple. Don't lock yourself into a tight corner. Let's go back to the nurse practitioner or PA chart review. If you pick 10 a week and you've got this experienced NP, there is no reason to do that. And if you put that 10 in your policy, you must live by that on a survey. So you really want to put what works for you. You can always do more. If you see something's going awry with somebody's care and you want to review more charts, you have every right to do that, of course. But don't put it in your policy that we're going to do this exorbitant amount. I know you know how busy we get, and it's hard to keep up something like that. It's all those New Year's resolutions. So if you make them too steep, we don't keep them. Know what requires a policy, and we're going to talk about that. Policies and procedures are personalized. If you go to one of the wonderful consultants out there in the rural health clinic world, and by the way, I understand you work quite a bit in Oregon with Katie Joe from Withley. She's excellent. We work with her quite a bit and see her clinics for accreditation. If you buy her policies and procedures, you must personalize them on your own letterhead. You can't leave them on her letterhead, and you must read them because you may not agree with every line in there. And there are policies and procedures available on the internet you can buy, but they need to be yours. Staff should be familiar with policies. They should know based on their job description. And then you must follow the state's physician on-site and chart review regulations. So we need patient care policies. We need a biennial review of policies by that advisory group, including that outside person. We need policies for storage, handling, and dispensing of drugs and biologicals. We need emergency preparedness policies for sure. We'll talk about those in detail next week. We need a policy for health records. If you are a provider-based clinic, typically there's someone at the hospital who is in charge of health records. It is quite acceptable to put in your clinic finder that the clinic follows the health record policy of the hospital. And of course, that person is the responsible person. That's quite acceptable. You need a policy on HIPAA, and that's also the same for provider-based. You can follow the hospitals. You have to have your scope of services provided and referred. You need your lines of authority spelled out. You can do that in an org chart, but you need it spelled out. Your categories of practitioners. So we'll have 1 MD, 2 NPs, 3 RNs, whatever it is that we have in our clinic. And a policy for how you're going to maintain your equipment. How do you clean it? How do you get it checked once a year? Those kinds of things. And a policy for infection prevention, very important. If we're sterilizing instruments, that's even a special place in that policy. Hand washing, of course, we'll add that back in this year. Hiring, training, and orienting. So if we're provider-based, that's going to be based on the hospitals. Usually the hospitals' hiring, training, and orienting is the same for everybody, all their entities. So you would use that, and that's fine. If you're independent, you need to have a hiring schedule. How do we hire? How do we orient? How do we train annually? Quality improvement, of course. And then the biennial evaluation. Usually be called the annual evaluation. That is now biennial also. So we'll talk about that next time as well. Survey findings. So if you have a survey today and you're 100% compliant, then you're good. You're good to go. And you must be 100% for rural health clinics. If not, and there's standard level deficiencies, a statement of deficiency will be issued to you within 10 business days. These laws were written by the CMS, not by the creditors or by the state. A clinic has 10 calendar days to submit an acceptable plan of correction. So they give you the statement of deficiencies, you write your plan of correction. The day that the state or an accreditation organization like ours gets an acceptable plan of correction, you're accredited, okay? Now, for standard level deficiencies, you have 60 days to correct those deficiencies. So if you write in your, let's say there was no chart review. So you have 60 days to correct that, but you're going to put your plan in writing and you're going to give the date within 60 days. You're going to say by March 1st, we'll have all the chart reviews done. That's still an acceptable plan of correction. You may be asked to provide that evidence later, but it's not going to hold up your accreditation or your approval with the state. Condition level deficiencies, if you have a CCN, require a resurvey within 45 calendar days, and that is a very strict CMS rule for states and accreditors. So it's from the original survey date, you can plan on being visited again within 45 days. And if you can't pass on that one, you're at the risk of losing your billing number. That's why we always love to talk about accreditation, because we stay with you. We find so many states are taking so long to get out to resurvey that it puts you at great risk if you're not on top of this. And the reason seems to be that you're so busy seeing patients and taking care of people that these compliance things kind of fall by the wayside, which is human, put it that way. Now, some trusted resources. If you certainly will have this slide presentation. You can have our standards should you wish. Is the National Association of Rural Health Clinics, which is your lobbying and advocacy group in Washington, D.C., and your educational group for the two meetings a year. Certainly the listserv that you know about, but National Association of Rural Health Clinics is the premier rural health clinic organization in the country. HRSA, of course, has policies, procedures, and all kinds of things on their website. NOSOR, your state office of rural health, which you know about, is an incredibly good resource for information. And they're actually working on some new releases this year on information to help rural health clinics. And then RHI Hub has a lot of information for the rural health clinics. Now, that's the first half. I wanted to leave plenty of time for questions. Ron, Deanne, do we have any questions? I have to do this way. I'm sorry. I have to unmute everybody. Let's unmute. Okay, everybody should be unmuted. While you're deciding if you want to ask a question, there's my contact information. Feel free, please, to best would be to email, and then we can set up a time to talk if you need to talk. But email there, khealth@complianceteam.org, and then there's also another one if you want to not come to me. The questions@thecomplianceteam.org. What kind of questions you have?
I have a question for you, Kate. This is Randian.
Hi.
Can you have plants in your waiting area or in the clinic anywhere? Is that a problem?
Not a problem at all. The only issue would be something extremely large and heavy that could fall over on somebody, but that's not usually the case. No, there's no reg against that at all. Good question. Oh, the other thing that I get asked a lot about waiting rooms is books. I actually talked to someone from the CDC, and he said, let me know if anybody ever got sick from looking at a book that had some germs on it. That was his response. He said, don't worry about books. You can wipe them down if you wanted to, if you have sick children and you know that's the case. You've got a sick waiting room for kids, but there's no problem with having books in the waiting room.
So also, what does happen to a
Quiet group here.
What happens to a clinic when they don't pass their recertification?
Well, then they're put on a countdown. If they can't pass on the second visit of 45 days, they're on a track for decertification, for becoming a primary care practice. Yep. That's why this is so important.
So can
and have to, if you wanted to be a rural health clinic, you'd have to start all over, new 855, start from scratch. It costs you some money and some time, and a lot of loss of billing in the process. They can come back, yes.
Can you guys hear me?
Yes, I can hear you.
Oh, good.
How are you?
I wonder if I had a microphone. Hey, I have a question. So we don't have a nurse practitioner or a PA. We just have a DO. Would that disqualify us from the RHC program?
Well, are you already a rural health clinic?
No. No.
Oh, you're not. Yes, you would.
No.
You could not pass. You could not pass survey if you didn't hire one of those. You would have to hire one. Yes.
I see. Okay.
And yep. Yeah, that is the regulation. Remembering that the program was put into place because of lack of primary care physicians in rural areas, and so that's one of the big requirements. Yes, NP or PA.
Okay, NP or PA. Okay.
Sorry. Rhonda Ann, I thought there would be a lot more questions. I know they're there because it's never not a lot of questions. So if you folks want to think of them and email me, or we can talk about them next week, I'd be delighted to answer your questions.
Kate, hi.
That's a bad one. Sorry about that. I don't know what does that.
Hi, this is Linda Compton. Can you hear me okay?
I can hear you fine.
Hi, Kate. I work for the organization that we have 4 rural health clinics. 3 are provider-based and 1 is independent. They're all owned by our main hospital. Does the independent clinic have to provide their own separate employee chart if the hospital manages it under our HR?
What, an organizational chart? Is that the question?
When you discuss the employee HR files, does the independent clinic, rural health clinic, have to maintain those at that clinic if our hospital human resources department manages and maintains all that?
No, they could be at the hospital. The hospital still owns them, even though they're not a provider-based clinic, correct?
Yes, correct.
Yeah, no problem at all. No problem. Yeah, there's no law about where your HR files sit at all.
Perfect, thank you.
Okay, Kate, well, we're not doing
Okay, well, thank you so much. I hope that was helpful, and I look forward to next week.
Thank you. It was helpful. And yes, we will have the RHC Compliance 201 next Wednesday. Thank you, Kate.
Okay, thank you. Take care.
Bye.
Bye-bye.